for example, at Maharaja Agha Singh Medical College in Hisar. So I have this vast experience over the last 15 years as practicing radiologist. So currently I'm pursuing my Masters of Translation Research in Canada, and I'm focusing that on applied AI to radiology. And most of you as are engineers with little clinical exposure, but healthcare today is a team science. And your experience in algorithm and machine learning can directly influence how patients are diagnosed and treated. So I'll be directing my studies, my presentation to a non to be less of a medical terminology, but uh, I'll be discussing about how radiology is facing real challenges with heavy workloads, reporting delays, and shortage of specialists, and where AI and your skills as engineers can make a real difference, helping transforming the way we deliver the care to the patients. So over the next 90 minutes, we'll cover a basics of medical imaging, image enhancement, how AI can reduce the noisy data, how the decision AI makes the decision and it can help us interpret images. What are the real world tools? For example, the CADX and CAD-E and companies like Claritas, Health Tech, and Tempus. So I'll be discussing about them. We'll also discuss about challenges, ethics, and role for clinicians and engineers very briefly. And my lecture won't be a heavy medical lecture. It will be very simple, and I'll try to move with real world opportunities and examples. So let's start with the numbers first. That had always shocked me and everyone that India has only one radiologist per every 1 lakh population. In Canada, the number is closer to 7 per 1 lakh. That's a sevenfold difference. And the burden of disease in India is arguably higher. And if we think about the rural areas, some districts have no radiologist at all. Patients have to travel hours for the reports. I worked in a government institute and I know what's the workload over there. I a radiologist had to read around 100 plus scans a day, and we were tired, we were fatigued with reading that. And there are chances that we might have missed or we miss small cancers or very fractures or other pathologies. So that's what the scenario is. Urban centers in India are better managed, both in India and worldwide, but the reality in the rural and tribal regions is a pace of paradox because of higher disease burden and fewer specialists. So I think this the problem that I'll be discussing today is the scale problem, because we can't produce radiologists overnight, but technology algorithms such as cloud platforms, AI can extend our expertise just like distributing computing. So that's why augmentation matters, and tools that enhance our vision and sports decisions are essential. So before I dive into I want to explain what radiologists actually do in their life. So many of you might think that we just look at the imagings or the X-rays. In reality, it's not the way. It's a structured pipeline, like much like the way you handle data in your engineering field. So we start always with the acquisition of images. The scan is performed, and we are assisted by the technicians and the other paramedical staff. They conduct our X-rays, CT scans, and MRs, and radiologists ensure that right test is ordered and conducted. For example, in a case of stroke, CT or MR is a crucial choice. So that's where we have our role in the first stage of the acquisition. The second stage that a radiologist has a role is the enhancement. Once we receive the images, so radiologist has to look over the images and sometimes have to use filters and reconstruction algorithms to improve the image quality. That's very similar like to your process of pre-processed data extraction and the way you enhance scans for clarity. The third step that radiologist does is an interpretation. That's the core part of our work. Reading images slice by slice, single organ by organ, finding pathologies such as tumors, fractures, clots, and what looks like a shadow to a routine person or a layman might be a cancer for us. So it's a very crucial part of our work. And once we have interpreted these images, we move on to reporting. We turn these findings into a structured, actionable language so that it's clear for the for the referring physician to give an adequate treatment. Always give an example. For example, after reviewing all about 100 plus images for my CT or an MRA, our report just says left frontal lobe infarct, urgent neurosurgical referral or neurology referral. So this single line changes the treatment immediately, and that's a critical emergency. So the final part of the role of a radiologist is a clinical decision making. Our reports guide surgeons, oncologists, emergency doctors. So I always say, I said, we transform this raw data from these images into actual real clinical decisions, very similar to the data that data scientists does in your field. So this is a basic slide that shows the main tools that we use in our imaging. So X-rays are the most common and quick and affordable 2D images. A better version of them are the CTs. They are multi-sliced and they have multi-reformed algorithms, so that helps us to view these images in 3 dimensions. MR uses magnetic resonance. As magnetic resonance images uses magnetic fields, and that's very great for visualizing the soft tissues and brain activities, especially the functional MRI. We also use nuclear medicine, for example, PET and SPECT. They add an additional layer to our anatomical visions that we see from the basic imaging. They provide us the functional information of the body. And finally, the bread and butter of radiology, we call it ultrasound. It's safe, portable, and low cost. And especially in India and in rural clinics, it's easily available. So, and each modality is a different data language. CT talks in pixel, MR talks in signal, PET talks in kinetics. And AI had to adapt for each and sometimes have to translate among these different languages. So the question rises, why AI in radiology and why now? I try to answer this by 3 main reasons. The first is rising workload. CT and MR volumes all over world are rising. I have an example data from India, and I think so it's almost similar to that in India. So in Canada, this volume of CT and MR is growing by 8 to 10% each year, but the workflow is not keeping up. The second reason is variability. As a physician, we see very complex cases, and these are our opinions as a physician, and they vary. For example, mammography read by one physician the other physician won't see have the same findings, and call this as a reader variability. And especially in mammography, there is a ratio of 15 to 20% reader variability. That means out of 100 radiologists who read the same scan, 20 will find something else. So that's a second factor where AI can help us. And the third is delay. The average MR delay in Canada is 10 to 12 weeks. And for strokes, especially, every minute is important. 15 minutes delay can reduce recovery by 4 to 5%. So AI can help as a triage rule. It can flag urgent findings in under 5 minutes and turning hours into minutes. And this has a real world impact. So now let's move to CAD and the computer aided diagnosis. I want to start with, what does CAD mean? CAD stands for computer aided diagnosis, referring to using computer generated image analysis to support radiologists in decision making. It is important to emphasize that CAD is not replacing doctor. It's a supporting tool. The final call always lies with the radiologist. Historical, Historically, CAD research began in 1980, especially in University of Chicago. initially applied to mammography and chest imaging. Since then, it has evolved into a specialized CAD X and CAD system, which we'll be discussing later on. CAD has come a long way from early computer diagnosis in 60s and 70s to decision support tools in 80s and 90s. The first FDA approved system was in around 1988. While the US has moved quickly with adoption of CAD, India is still catching up. And this gap shows why collaboration between engineers and clinicians is so important today. Now I want to a bit clarify the two branches. The CAD E, that's for detection. It finds suspicious areas in the image, as shown in this image. So this is a CAD E system that detects the abnormalities. CAD X is the diagnostic branch. It helps characterize what the suspicious area might be. That means the area that's been abnormal detected, is it malignant or benign? For a layman language, we want to talk is it cancer or not? So this is something this CADX system does. And together they both improve accuracy and efficiency in radiology workflow. To simplify, we can say that CAD E is a spam filter flagging potential spam emails, and CADX is a classifier that tells you if it's truly spam or just a promotional email. A CAD system works step by step, much like your AI and machine language pipelines. It begins with pre-processing, where the images are cleaned and enhanced, similar to noise reduction in signal processing. The next step is ROI detection, which highlights the suspicious regions that needs closer attention. Then comes the feature extraction that captures measurable patterns that could be shape, texture, or intensity. And once the feature extraction is done, its segmentation follows, separating abnormal tissues from the normal tissues. Finally, the classification labels the region as abnormal or benign or malignant, cancerous or non-cancerous. So this is a basic CAD system. And here's how CAD fits into the real world workflow. A medical image, for example, a mammogram, ultrasound for the breast that we do, it's in a digital form, is put into the CAD system, which processes and produces an output. This output is reviewed by the radiologist and who makes the final interpretation. So the key here is the partnership. CAD doesn't replace a radiologist, but reduces errors and improves the efficiency. Now, briefly about the CAD system. As discussed, its focus is on detection. It can help catch problems that a doctor might otherwise miss by flagging even very small or subtle changes. And at the same time, it is designed not to raise too many false alarms, so the doctor aren't overwhelmed with the unnecessary alerts. So I always say its CAD E system is a second ranger, a safety net for radiologists. I have in the next slides, I'll be showing you examples for that. For the CADX system, it goes one step further from the CAD E. It further assists in diagnosing the pathologist. It can differentiate between is the lesion cancerous or non-cancerous. It also can predict if the tumor is aggressive or not. And this it does this by providing a probability score that helps physician to make treatment decisions. To simplify this concept, I we can think as a CADX is an analytical engine of a medical AI. It doesn't just highlight something abnormal, it helps decide what the abnormality means. That's my first break, and if you have any questions, I'm ready to have that. Do you want
So,
me to continue or?
well, I was just going to say, maybe we'll just, I mean, does anybody want to ask a question in the middle? It's always nice to take a break, for sure. Um, but does anybody have any? Yeah, well, we do have a question.
Yeah, sure.
Analyzing. So what is the specific tools, the famous tools that we can utilize in our research? Yeah, so actually, it's a great question that you're going to answer in the next in your next part of the of your talk, right?
Okay,
So
yeah.
the question is,
I couldn't hear the question. Sorry, I couldn't hear that.
just asking more specifically about the tool. So meaning like you
Yeah, I'll
just
be discussing my next part. First part was about radiology and why we need CAD systems. So now I'll be discussing what are our tools. And
yeah,
if
exactly.
everyone is okay to go, I can resume my talk.
Yeah, I mean, unless anybody has a very specific question, no. Now, why don't you just continue? It's great actually. So
Sure, sure.
everyone's enjoying it. So just keep going. Yeah, for sure.
So now I'll be coming to the major part of my talk. The two main roles of AI in imaging. First is the image enhancement, where algorithms cleans and sharpen the raw data. And the second step is the decision making part, as we discussed, where AI helps radiologists to detect disease pattern. So this slides introduced to the first of our two pillars, the image enhancement. You will immediately connect this to a concept of noise reduction, signal processing, and feature extractions. But for us radiologists, image enhancement is not about beauty. They are about accuracy and safety. Every pixel represents crucial findings with potential to affect life and death decisions for the patients. S- Image enhancements means improving the visual quality of the medical images so that abnormalities are more visible and interpretation is easier. In practice, poor quality images can cause misdiagnosis, poor outcomes. Better images means faster reporting, fewer repeat scans, lower cost for the patients, and less radiation exposures, especially in the CT spaces. So we have looked at what enhancement is, but how do traditional mathematical methods compare with the new AI based models? That's what we'll cover next. So this slide connects the two words, engineering words of algorithms and radiological word or medical word of diagnosis. So traditionally, radiology used fixed mathematical tools like filters to smooth noise, histograms, equalization for contrast, edge detection for borders. Useful but rigid. They treated every patient the same. With current technology, AI powered models, especially deep learning, learn from thousands of paired images. They predict missing details among these images, reconstruct sharper outputs, and adapt cases by cases. For example, in this image, your image on your left is a grainy and very not that sharp image. With the AI model, it was able to produce a better and sharper image quality of with the very same scan. So that's what we are talking about. So if you want to for a we can think in this way that traditional methods are like using same Photoshop presents presets for every photo, whereas AI is like an artist who adjusts every image uniquely. Now let's see how the difference looks in practice to a case study. So here you'll see brain MRI images or slices after enhancement, and there is a cancer in this brain patient. So you'll notice the image quality gradually becomes clearer from A to F. The core image idea of the image enhancement is to improve visibility of anatomical and pathological structures by reducing noise, increasing contrast, and sharpening the details. Think of it like adjusting brightness and contrast in a photo, but there are stakes are much higher. Every pixel could make the difference between detecting or missing the tumors, or change in the size of the lesion, which can tell a physician if the cancer or the tumor has responded to the treatment. So it's very important. This is another case which shows convolutional neural network can transform raw MR data into sharper diagnostic quality images. On the top row are raw data. blurred and noisy. And on the right, the C and D images, you can see CNN significantly improved the quality of the image. The images are more crisp and sharp and easy to see. So, and if you see quantitative data evidence is also available for the similarity score for 0.66 for the top row and 0.93 for the lower row. So I can correlate this way, like moving from a low resolution video stream to an high definition images, and that's achieved through a algorithmic learning features like edges, textures, and contrast. So for as a clinical context, I say that it's a better images means faster and more confident diagnosis and less repeat scans, which means it's high volume, especially in a hospitals with high volume. This is another case. So these are the MR images. So MR, we often use contrast injections, especially the gadolinium. It's a very costly and the process is time consuming. So also there are some safety concerns with the contrast administrations. So with the help of AI, it enables us to simulate full dose images from low dose scan as seen in this images. This is a low dose scan and this is a synthesized AI image that gives very similar images to a full dose post contrast image. So you might ask why this matters. So contrast agents are expensive. Avoiding repeat injections can reduce costs and protect patients. We can think of as a rural setup and anywhere in India where resources are scarce. This innovation is a game changer for that part of the world. So and AI based algorithms are can help the hospitals and radiology centers to perform safer, cheaper imaging without compromising the quality of the scans. This is another clinical commercial application known subtle PET TM. It is it improves the PET scan quality using AI. If you look in the middle scan, the scan is acquired in just 6 minutes compared to the usual scan which takes around 24 minutes. So you were able to do it at 4 times faster than the traditional scan. So that's where AI is playing. Faster scans means shorter patient waiting time, more patient serves the same day, and less radiation exposure. So to finally summarize, AI is already making an impact in CT and MRs. For example, examples includes patient positioning, automation, scan range selections, artifact removals, and gadolinium dose reductions. If you notice on this image, the range of AI models applied, CNN, GAN, UNET, each has a niche role. For radiologists like me, these tools save time, reduce errors. For patient, it means faster scans, fewer repeats, and lesser radiation or contrast exposure. And if I think of an Indian context or my experience, many hospitals that I worked had older scans and they didn't have the financial capability to update their scanners with the time. So I see as AI based algorithms allow them to get high quality images from their existing machines, extending the life cycle of their machines rather than replacing and going for a new one. Now I'll move to my next part of my talk is we'll connect our discussion to two real world platforms where AI is actively applied, Claritas Health Tech and Tempus. These companies represent two ends of the spectrum. Claritas focus strongly on medical image enhancement, whereas Tempus brings AI into clinical decision making using big data and genomics. For me as a radiologist and you as engineers, this helps frame the difference between improving the image quality itself and improving the decision we make from these images. As we move forward, I'll be highlighting how both play complementary roles. especially in countries like India, where access to high quality imaging and efficient diagnosis can be limited. Claritas Health Tech is they developed an IRAD software. This is an FDA approved software used for enhancing MR, CTs, and X-rays. So the main function is it works at the pixel level, enhancing the contrast and details without distorting the image. So this is an example image from a it's an X-ray of a hip. So the box that you see is the Claritas software that enhances the image quality, and the side panel that you see is the regular image. So the scan has been done on the very routine, machine that the hospital had, but with the help of this software, the image quality was drastically improved. So a physician is able to see very subtle changes that can be easily missed by the naked eyes. This is another example from Claritas. So Claritas had this customizable controls, so you can move around between AI and the original images. For example, in this image, this is a normal chest radiograph that was taken with a routine image. But as a physician, for me, with having worked for 15 years, it's very hard to say there is a something behind the heart. But the software was easily it deducted the overlying soft issues and able to show that there was a consolidation underlying. So that's the rule of AI. So now we'll move to Tempus. Tempus takes a different approach. Instead of only enhancing images, they focus on entire clinical picture. Their platform integrates imaging, genomics, pathology, and clinical records. The idea is to use machine learning to support personalized decision makings, especially in the cases of cancer. For example, Tempus may analyze a radiologist scan along with genetic data and previous patient outcomes to suggest which therapy will work best for the patient. So it's more of a personalized treatment decisions. From a radiological perspective, this changes my rule. I'm not just reporting what the images shows. We are contributing to a multimodal AI system that supports the oncologist and the entire care team. In India, where the precision medicine is still emerging, such platforms could leapfrog the traditional system, but the cost and infrastructure and data integration is a big challenge that I see. This is an example image from Tempus. So it's a platform that AI, especially used directly towards the radiologist. This solution is designed to optimize how we read images or detect pathology. So I'll just simplify. These are the CT chest images, and the lesion this is a lesion or the tumor that's been automatically measured by the software, and this is being done with just one click. So this software, it finds the pathology, it with just one click, it measures it, and it gives a report. So it's an automated reporting that generates, and it helps reduce the turnaround and improves consistency. Importantly, it's also equips clinicians with advanced insights, so that can be supported by the data. So the best part about Tempers, it's packs. It has a very it has integration with the packs and electronic health records, so it's smoother to adoption. Now I'll talk about the platform that goes a step further. That's turning complex brain images into a usable, quantifiable data. This platform is Claritas NeuroCloud. It's a cloud-based platform that analyzes MR and PET images, and instead of just relying on the radiologist eye, it provides objective numbers and visualizations. For example, for brain, it provides metabolic maps, the brain atrophy volume, and lesion count. that currently is subjective that we do, but now we have an objective software or solution that provides that. So let's see how this works in a real clinical problem, especially dementia and stroke. So this is a report from of an Alzheimer patient on this software, and this is a PET scan. We call it's a positron emission scan, and that measures the brain metabolism using a radioisotope. So low uptake in certain regions suggest Alzheimer's. For example, if you see it's decreased uptake on the parts of the brain, so that's what's suggesting it's that part of the brain is working less, and that gives us a prediction that it's Alzheimer's there, and based on the particular distribution. So traditionally, this is a subjective. A radiologist compares the scan to the memory and our experiences, but NeuroCloud quantifies this by generating the Z scores, as you see on this, and this helps to differentiate the patient brain from a healthy control database. So now this provides a radiologist and a neurologist with an objective and data-based report. Here's another example from NeuroCloud. So these are axial, sagittal, and coronal MR images. So, and if you, we can see there are sulcal spaces that are opening up. So that demonstrate there is an atrophy. But currently, it's our visual tool that with our experience we are able to say that. But NeuroCloud automates this by segmenting the brain. It's calculating the hippocampal volume that's important for the Alzheimer's and comparing it to the matched age matched norms. So finally giving you a score, a quantitative data. So and that's very important. It's critical for planning surgeries and tracking pathologies such as MS. Impact of such type of software for a radiologist, it's less variability, faster scans, and quantitative reporting. For a neurologist, I see it's a better diagnosis, better disease tracking, and decisions. For patients, the impact is earlier diagnosis, fewer misses, and consistent care. I'll just compare both these. I know it's a bit heavy. So just so comparing the image enhancement and AI enabled decision making. Enhancement is more about making images clear, using the filters and AI softwares to reduce the noise and sharpen the details. Whereas AI based decision making goes a step further. It combines imaging with your electronic records, pathology, and genomic data to guide diagnosis and a step further with the treatment. So the dependency in both these platforms is different. Enhancement relies only on the scan quality, whereas decision AI relies on data richness. And practice, for example, as I showed, Claritas IRAD improves the images, whereas Tempus integrates data to guide precision therapy. So that's my second part of the talk. If I'm open for questions.
Any questions? All good. I think. Oh, wait. We do have a question. Tempest has a lot of massive data sets. So, 1.3 million images. It's actually accessible to the other workloads who have software. So the question is from Tempest. You talked about all the data that Tempest was using, right, for its training, and the question is any of that data accessible?
Pardon, sorry, I didn't get any of these data is accessible?
Yeah, is it accessible for us, for public
No,
use?
that's not. So these data, especially for healthcare, any data is very secure, and it's not for the public domains. So
Yeah.
there's, but the thing is, it's especially the Tempest. It's a very, it has very huge data in US, and so the integration is there, but for a general public, it's not available. So no one can access that because of the privacy reasons and the laws related to the medical health data.
Um, you'll give me 30 seconds. Is that okay? Maybe that'll
Yeah,
be the
sure.
break. Because that was an excellent question, and I'm gonna address that question because it's something that comes up all the time. So as engineers, you're going to be developing software, and you're going to think, if you wish to commercialize it, exactly what Parliament was talking about for Tempest and for Claritas. You're going to want to safeguard what you've developed, correct? So that's intellectual property. So I'm not going to go into that today. I might go into it a little bit tomorrow. But you need to safeguard it, because if not, everybody can do it, correct? So I don't want to burst your bubble as an engineer, but software is not protectable, okay? Because what you're using generally is open source, correct? You're using open source libraries. So you cannot get a patent on your software itself, on the code itself. You cannot get a patent. What you can do is not share your code. That's called a trade secret. And if you don't share your code, maybe no one else in the world can figure it out. But come on, there's a lot of smart engineers in the world, especially in India. So the chances of you being able to generate code that is not possible for someone else to figure out is not realistic. So a trade secret may slow things down, but it's not going to protect it. So here's the question. How do you protect your product if you commercialize? If you can't protect your code, everybody can do it through the data. So the only way you can actually have a business like Claritas or like Tempest or like the many other companies is because they negotiated purchase, essentially. It's not purchase, it's rights to data that they trained on successfully, and they are not going to share that data so that you can do it. That's the reason you will never gain access to that data. Because if you do, then you can actually build a company around that and be a direct competitor to Tempest. So they would never do that. Does that make sense? Here's the other problem, and then I'll give it back to you, buddy. The next problem is there are so many Kaggle data sets out there, massive data sets that are made public, correct? Well, if you read the fine print on pretty much all of those data sets, you will see that it is prohibited to use that data for commercial use. And that's the reason why, once again, is that the people who, the institutions that chose to share that information for research and academic research, they did not want to share it if someone's going to profit from it, right? So, institutions, including in India, institutions, especially private institutions, need to make up their mind. Are we going to negotiate a legal contract with a company to share the data, and in return, they're going to benefit through the use of the software and profit? Or they may decide we're going to share our data with an academic institution or, Kaggle or whatever, to further research. And so then they want to be safeguarded as well. So there's always an agreement with data, because ultimately, all this data belongs to who? You. It's your data, right? And that's the problem, is you are the owner of the data, not the institution. The only little twist on that is if you go to a private institution, when you sign up and go into the private institution, you are agreeing that that institution has privileges on your data. So you have to read the fine print when you sign up to a hospital, depending on where you're going. If you're in a public government-run hospital, I suspect that in India it's the same way, then the institution is a custodian of your data, not an owner, a custodian. So they cannot just give that data to whoever they want. But private institutions, sometimes they force you to agree that the information that they collect from you, they are allowed to do whatever they want with it. So anyway, so that was a caveat. That was a little interlude. There you go. Thank you very much, sir. We'll let
Thank
you
you
finish
very
up.
much. Yeah, yeah, sure. I'll do my third part of the talk. So yeah. So now I'm moving to the major part. So I move from the principles to the practice. CAD-E and CAD-X are just no longer research tools now. They are already in use and helping radiologists diagnose cancers and other disease more accurately. So my goal here is to show you real world clinical applications and how these systems are being applied in radiology. So CAD is now being used across breast cancers, lungs, and colon cancers, and extending into multimodal imaging. In breast, it's being used to detect, it's able to detect subtle microcalcifications and mass early. For lung cancers, CAD systems are able to flag small nodules and track the growth over time. So that's what CAD is currently able to do. So, in big picture, CAD is helping in improving the detection and diagnosis. So, I'll start first with the breast imaging, and breast imaging is one of the biggest success stories for the CAD. It helps detect and classify early signs for breast cancers. For example, on mammography, it's able to detect masses and microcalcifications. I'll be showing you examples for that, which are easily missed by radiologists, even with a significant experiences. So, with other modality rather than mammography are digital tomosynthesis. CAD has also shown to improve 3D detections among this and reducing the false negative cases. So it's very important, especially in patients with heavy breasts or with denser breast tissues, where it's very difficult to find out these small malignancies. So now I'll just connect the CAD pipeline to the real world impact. So because at the end of the day, these models matter only if they saves life. So if you start on this image, this is an mammography image, and CAD is designed to pick up subtle abnormalities that eyes usually doesn't see. Because if I see as this, I am not able to identify any pathology. But the pipeline the CAD uses is, it starts by pre-processing by removing the excess unrequired noise from the images. So it removes the backgrounds, segments and isolates the pathology. For example, in this image, it removed the pectoralis muscle which obscured. That's very well seen here. And then it enhanced the images so the lesion was well seen. If you see, very subtle seen on these images, and on these images were not that. So that's how the pre-processing was done. Once the lesion was identified, the software segmented the lesion through various thresholds and analyzing them for their shape, texture, pattern. And finally, that's what we call the feature extraction. And using the classification system, it was able to label them benign or malignant. So, especially for breast cancer, early detection is critical for survival. And in areas where there is excess workload or rural access and very limited mammographic or old mammography machines, this becomes a challenge. So AI can act as a second pair of eyes in these cases by flagging the suspicious regions. For example, in these mammographic images, so the AI was able to flag the lesion by circling them, and that's how AI rules. So it's the second pair of eyes for the radiologist. So, and it's not making the diagnosis, it's just assisting a radiologist to look over the pathology and then classify it. So it can be very useful in resources areas, especially in areas where there are very high volume, or especially in countries where, or the areas where there are very limited resources. Next, we'll be moving to the lung cancers. So for the CAD, it's mainly detecting the nodules. So radiologists face challenges because these nodules can be very tiny and they look like blood vessels or a benign scars, and that can be easily missed because we see them routinely. But when followed up over time, these small 3 or 4 nodules is found to be a malignant because it grows very fast. And if detected on a time, it's very helpful, but usually it's not the case. That's where CAD system helps us. It can pre-process these images and segment the tissues to flag out the suspicious nodules. It can also analyze that nodules features, the shape, size, and growth that as a radiologist we do, but it is more objective. So AI can help us is helping us with this, classifying these nodules benign or malignant. So this is a chest radiograph. So this is a AI software that was able to flag up nodules, which actually was difficult to see because of the shadowing and overlap of various structures. So, but once they were flagged by the software, so it gives an opportunity for a radiologist to evaluate them and then make a decision. Especially in this case, this subtle nodule along the right heart border that was subjective on the overlying on the spine on the lateral view. So this was a mass, and that could have been easily missed if a radiologist has been reading this in a very busy center. This is another example for a radiograph. If you start from seeing this chest radiograph, we don't see anything over here. But with this AI software, the deductions, and it was able to generate the CT images, and that's the nodule that you see. And if you go from A, B, C, D, that's it's overlapping, overlapping, and overlapping. So that's the nodule that was overlapping the vasculature and easily missed on a chest radiograph. So AI plays a significant role in detection of these nodules. Another role that AI has is in the CT chest. So measuring and detecting the nodules, and then it helps us in serially following up these nodules, because early detection of growth can change the therapy for the patient. So if a nodule on a consecutive 6 month, if a patient is scanned after 6 months and nodule has grown by 3 or 2 for a subjective objective eye, it's very hard to assert. And we have this measurement variability among radiologists. So but as a AI software, it's easy to detect and it is easy to follow up nodules. This is another example. So these are chest radiographs. This is an old image from an earlier version. Sorry for the quality. So if you see, there are irregular margins and v- very faint irregular margins. So it's very hard to say is it a pathology there or not. But with the AI software, the software deducted the from this. So these are the ribs that you see. So the AI deducted the ribs from this image, and now the abnormalities are easily seen. And there was a lesion and inflammatory pathology in the lungs. And this is example of how AI is used to detect inflammatory disease and especially tuberculosis in India. So not in India, but it can be used. This is a case of tuberculosis. So AI systems like CAD4TB are used to screen chest X-rays, and this is can be used in rural clinics. This is another example of a radiograph. This is a lateral chest radiograph, and in a normal routine day, when I'm, for example, I'm reading this case, I'll see this and the spine is not that clear and it's easily I'll miss it because but once the software labeled it, so I'll be more considerate, and if I see on a zoomed image there was a fracture that could have been easily missed So this is AI acting as a second reader, preventing the missed pathologies. Now I'll shift from chest to abdomen. Abdomen imaging has is especially important in countries like India, where we see a very high burden of disease like liver cancer, gastrointestinal tumors, and traditionally this diagnosis depends upon CT or MR, or patient is symptomatic, that we have to he comes to the physician. And for CT and MR, we have hundreds of images per patient, and this makes radiologist workload extremely heavy. We have to go individually from these images, producing, getting the reformats and all other modalities. So the the workload is more excessive. So here is an example of CT colonoscopy, w- where a computer aided diagnosis was able to find that polyp. So what we say, usually these tumors, when they are small, they are as a small polyp or a nodule, and it's very subtle. If you see on these regular axial and coronal images, it can easily be missed by anyone. But with the help of the software, it was able to label that, and the radiologist was able to identify that, and then request for further evaluations to make the diagnosis. This is a similar case. uh, if you see these are the colon images, I have zoomed them up. So these are the normal hostra that we have in a normal patient, and there is very subtle nodularity that could be easily missed, and it's always missed by us because it's too subtle. If you see, it's almost similar to the other hostras, but the AI software was able to detect that and raise an alarm to the radiologist, and based on the clinical history, this lesions could be further evaluated. So we have seen the use of CAD in chest and abdominal imaging. Now let's look into the other ways where the CAD technology is being used. So for brain tumors, this AINA's enhanced MR are able to detect tumors, and they are able to segment them and characterize them too. AI is also providing a significant role in stroke management and aneurysm by identifying and s- speeding up the process of evaluation of these scans. So I'll be briefly discussing about the neurological component of CAD technology, and especially this is an example for a stroke patient. The white thing that you see here is a blood that this is an elderly patient with a large bleed. So in a very busy center, this patient, the scan might have been done, and it's been waiting for a radiologist to see them and analyze them. And there could be a gap between the scan and a radiologist being seen. For example, in my experience, the technician used to do the scan, and the images were transferred to me after around 30 minutes or 40 minutes, and I already had some work. So the patient, the moment I start to read this patient, it was a gap of 2 or 3 hours, and so in some centers it was more based on the workload. So these critical findings can easily be missed. But here in the system, so the workflow that goes with the AI system is that once the scan is done, the AI system picks up this bleed. It goes through the ICH detection algorithm, alerts the reader, and puts that into a stat list. And it's triaged in a way that now the scan has to be read in a immediate manner. So that's something where the neurological imaging, the AI and the CAD is playing. This slide shows, as we saw in the previous case, for hemorrhage, it was a matter of speed and timing. But for malignancies, it's more of precision. So MRI offers a great soft tissue details, but the thing is, there are excessive data. There are lots of images, various sequences, and finding them as something, a small nodules or small lesions is finding a needle in this haystack. So AI, by labeling these lesions or marking these lesions, can highlight them and speeden up this process. As in this case, there was a small meningioma that was highlighted by this software. For heart disease, as we all know, it's a leading cause of death worldwide. And India, it often strikes earlier in life. So detecting it early relies heavily on imaging. But the expert doctors are limited and very inhomogeneously distributed. So AI is changing this. It can measure and detect blockage on non-contrast CTs. It's able to measure the calcium deposits on scans, non-contrast CT scans, and give a predictive values for your risk to have a heart attack, so that you can have a pre-plan your treatment, have a better prognosis. So it's playing a significant role in nuclear scans as on the SPECT image. So it can evaluate your heart mm, physiology. It can track your wall motions and even draft your reports. So with this cardiac MR, it can automatically measures your heart pumping and with a high level of precision. So now moving, summarizing this and the benefits of AI that I see is AI is being adopted because it has an impact. It has an impact on the outcome. It is able to detect disease early. For example, finding the tiny deposits in arteries long before the symptoms started, especially in cases of coronary artery calcifications and stenosis. It enables personalized care by segmenting heart chambers and analyzing them. It also reduces the delay, especially in busy hospitals, helping in triage urgent cases, as we saw in the patient with intracranial bleed. Ultimately, AI is helping us in making fewer misses, faster care, and better survival. Having talked about AI, and I want to talk this, AI has its limitation. First and foremost is there are false positive, flagging normal findings as abnormals, and this can cause unnecessary test and cost. For example, in the coronary, in the abdominal polyp that I showed you, so these could have been normal abnormal findings too. Secondly, the bias and generalizability. The most models, the AI models that are currently being used, are trained on Western data. Applying these to the different populations, especially in India, so we might miss pattern of disease, especially tuberculosis or others which are more common in India as compared to the Western part of the world. The third limitation is the data need. AI requires huge annotated data sets. With in countries like India with a fragmented record and limited digitalization, there are hurdles, but an opportunity to develop the system and with indigenous datasets and better collaboration. Finally, the biggest hurdle that I see is workflow integration. Even accurate AI won't be of use if there's slow reporting. So pack adoption is important for that. Moving on to ethical and regulatory aspects, these are important as the technology itself. First, regulations. AI in healthcare must be validated just as rigorous as medicines. The FDA has already approved several radiological tools, but in countries like India, guidelines are still emerging. The second major part is the privacy. Imaging data is deeply personal. With digitalization and teleradiology, secure storage and transfer is essential to maintain the patient trust. The third ethical part is explainability of AI. AI is currently like a black box. Clinicians need to understand why the decision was made, why was the lesion flagged, and what was the final result. So that's something is currently the major part of it. And finally, the accountability. If an AI assisted diagnosis is wrong, who takes the responsibility? The software company, the hospital, or the radiologist? This is still an open debate worldwide. So, looking ahead, there are big opportunities for healthcare professionals and engineers to shape AI in healthcare. Firstly, with federated learning, training models across hospitals without moving patient data. Second, the real time CAD, image AIs, especially with uh, especially with when while doing biopsies or stents or the patients where it's live real time imaging is done. So the AI system needs to be very fast. There shouldn't be any less latency or edge compute. So optimization is very important for that. Thirdly, I see the future role in explainable AI. Clinician needs models that can understand and trust, and engineers can help AI more transparent and friendly, human friendly. So I just want to recap all my thing is, so I put every AI in imaging in three buckets. First is enhancement. It cleans up the images, sharpens details, reduces artifacts, and makes older machines useful again. CAD AI as a safety net, flagging nodules, lesions, and cancers so fewer cases are missed. CADX goes further, classifying patterns and guiding treatment. In summary, the three main points to close is CAD-E and CADX are adjuncts and not replacements for the radiologists. They work with clinicians, making imaging safer and faster and safer. They improve detection, characterization, efficiency, amplifying radiologist works. And finally, validation and trust is essential, and AI must be tested in the local population. And clinicians should be a part of that. Thank you. These are my references. And special thanks to Dr. Pascal and for his leadership and inspiration in AI.
Thank you.
Thank you, Dr. And it's been two questions.
So you can imagine in my field of my work, I sit through many presentations like this. But seriously, you really nailed it. That was a very nice presentation.
Thank you,
You
Dr. Pascal.
hit all the right points for where AI is influencing and assisting radiology. And I think what is difficult in giving a presentation like this, especially when you're a radiologist, is it is delicate because inevitably, if you're a radiologist, you can either be an early adopter, someone who sees artificial intelligence as an improvement, or you can see it as a threat to your job. And so it's always difficult to give a presentation where it's informative and yet positive. And I think that's what you just sat through. So thank you very much. That was really a
Thank
very
you,
good
Dr. Pascal.
presentation. Um, any questions for our speaker? Yes.
So these softwares, like where is it available? Is it available here?
Absolutely. So the question was where, or where can you get this software? Actually, why don't you give your experience in India? Like, what was available to you in the centers you worked at, and
Yeah.
was it limited or not?
Yeah, I can do that. So, yeah. So, I'll start with my initial practice. So, I had various levels that I worked with my career. I started my practice in a rural setting in a center that had an ultrasound and an x-ray. So, and that was very simple. And the ultrasounds in India, as such, our radiologist does. Here in Canada, it's been done by a technician. So our system was a radiologist used to do a scan, and we had around 100 plus ultra patients per day, and that was our workload. And it was very fast and super fast. And we used to dictate the reports to a technologist or a transcriptionist, and he used to type that on a computer. That was what was the system in India. And I'll compare that to Canada with my experiences. In Canada, the system is the scans are done by the technician and the images are sent to the radiologist to review. And we don't have transcriptionists here. We use AI based softwares as dragons to dictate into the computer, and the reports are generated. So that's the gross difference that we have. That's as my initial experience. Then I went into a medical college in Hisar, Haryana, and that was a tertiary hospital. So that had all the modalities, the CT, MRs, and full-fledged radiology department. So the experience over there was it was a government institute, so we had excessive number of patients. So workload was a lot there. So with that, and least we didn't have the technology, but with AI wasn't fully that came into the practice that time, but we used to use enhance the quality of images to the very basic softwares that we had and do the 3D reconstructions. Hope
Oh, yeah. Sorry, you cut out for a little bit there. Um, so it's a problem. So it's a great question, and it is also a challenge. And that is, it depends on the institution you're working in, right? So implementing software um, for radiologists to use in an institution is a legal issue, actually, because the delivery of care, um, you know, it's every institution that's what they do. And so it depends on the institution whether they want to provide that software to their radiologists. Right? It's always a tricky question because you use your phone, you use a calculator. No one regulates that, right? So as a radiologist, you can use a calculator. You can use software that you have on your phone. Ultimately, you sign off, correct? You're the radiologist. You sign off. So legally, you're responsible. You're signing off for that decision. So it's fine. So then why wouldn't you use any software you want? Well, there's where it becomes a problem. So if you use something that's on your phone, then you're personally liable, and your decision is yours and you're signing. But if an institution gives tools to their clinical staff, then they're liable for the tools that they're offering the clinical staff in order to make their decisions. So that is a huge cost associated. And so to answer your question, it really depends. And yes, there are many software available around the world, absolutely everywhere. Anyone who's willing to buy, like seriously, that's really where it's at, right? So Claritas, Hardeman was very kind in showing Claritas, who's just a strategic partner of mine. They support my research and I support them. They're just an example of a for-profit company that's selling around the world. But it's for profit.
All the image modalities.
There would be software for all image modalities, absolutely. Yes. Was that Claritas? Claritas specifically?
Yeah.
No.
Yeah.
So Claritas specifically, no. They're not a big fan of ultrasound. They haven't gone into ultrasound. Let's do that. That's what I do. But no, so no, not all companies do all modalities. But Claritas is specifically X-ray for sure. CT, MRI. Yeah.
And I'll just
They're really into that. Sorry.
I want to add something, Dr. Pascal. The thing was for us, the softwares were usually came with the machine that when it was bought, and it was institutional package that they came up with. So, and we didn't had the marketplace at that time. So to you buy the software, and most of our practice is mostly institution based. So everything software had to come and to this institution.
Yeah. Yeah, that's an excellent point too, and that could be like a whole week of discussions too, talking about the the environment you work in, because absolutely, generally software comes in with the devices you're buying, right? Because they're so expensive, right? So CTs and MRIs are very expensive tools, and so the agreements that are made with the institutions typically also include software, right? So meaning what software is going to be permitted to actually work with your PACS, which is another big expense, as well as the CT machine or the MRI or PET or whatever you're working with. And so usually, yes, the software is bundled with that. AI is changing that now because you only need the image. So as long as there's an agreement that you can funnel the image, to a node, where you have a server and you can process that image and then put it back on the screen. You can either have an agreement with your PAC system, you can have an agreement with your CT MRI machine, which meaning that it will be done at source or will be post processing, right? So it really just all depends on your setup for your institution. But that's probably what is slowing the integration of AI is all the agreements that have to come into play with all the different providers, the legal for your institution, and ethical use of the software is what's slowing the integration. In my personal opinion, I think it's a good thing. I don't think there's any rush for us to implement AI, and it sounds funny for me to say that because obviously I'm very much interested in AI, but I also realize that it takes time to do it properly, right? And so even though I think my algorithm might be the best thing ever, a little time to let it kind of ease into the system is not a bad thing, right? And so legal agreements is a very good way to slow things down, right? There are centers in Canada. There's one that maybe even Carmen works with, which is called Unity Health in Toronto. And so they are absolutely at the forefront of integration of AI. And they have probably about 30 or more now AI algorithms that are in clinical use, which is absolutely stunning for any one institution. And the reason they've done, or the way they've done that is through research. They've developed algorithms in-house, and they've implemented them in the clinical stream in-house through their legal system. So meaning that legal of Unity Health has approved the use of these algorithms in a clinical setting without having the requirement for Health Canada or FDA. Because ultimately, regulatory systems are for the sale of software. So if your legal of your own institution authorizes the use for your staff, your clinical staff, to use it and is willing to take the responsibility, then it's fine. And that's what they've done. That's actually changing now. I don't know about India, so someone who may know better than me in India, but in the United States, the FDA is currently in talks to solve that. So meaning that even if you wish legally to use an algorithm that you've developed in-house, you would not be permitted to use it without regulatory compliance. But that hasn't happened yet, but they're working on it. So they're going to shut that door, right? Because of, once again, the risk of implementing AI too quickly. They're saying, wait a minute, that's maybe not a good idea. But currently, anyway, you can do that. So it's interesting. That's one of the hurdles of implementing AI. Sorry, I hijacked that again. Any other questions for our speaker? Anybody? Yes, sir.
Can we get the demo? How to use that demo?
The demo, absolutely. You know what? I'm sure he'd be happy. Parliament would be happy for you to reach out and share. So absolutely, yeah, for sure. I'm sure if you Google it, so you'll get it. Yes. Any other questions? Yes, sir.
So, but in the Indian situation, right,
health is not still not affordable for rural. And what we are doing is like if somebody wants to have even X-ray CT, so they have to. One thing is cost. Okay, so they have to pay CT, MRI, 5,000, 10,000. It's not affordable. One thing. And other end is like we have in the government sector hospitals. So we have no technicians. Even the doctors dispatch that get the CT scan. So when we go to the lab, the technician is not available, or if the technician is not available, then they say that dye is not available. So it may be coming in the next month, and you will need to wait for the things. And so that is the situation in India. And if the AI also comes in to upgrade the machines and all those things, are we still complicating the things? Now, of course, it improves the accuracy, and maybe like how to make it affordable. That is my work.
Well, you know, you just, for me, thank you, because for me, what you've done is you have provided a transition to the next talk. So after tea, that's exactly what I'm going to be talking about. So if you'll permit me to not answer now, because that's what I'm talking about in the next talk. So it's exactly that. So you'll get a full answer on that in the next talk. Okay. Any other questions for our lovely speaker? No, I think it's time. It's time for tea, buddy. People are needing their tea. So, but you know what? Thank you again for joining so late at night. Time to go to bed, buddy.
Yeah.
And I will see you when I get back.
Sure. Thank you.
Thanks,
Bye.
man.
Yeah.
All righty. I think it's time for tea, correct?